Well, hello, and welcome to part two of this two-part webinar series, Promising Practices for Improving Access to Primary Care in Northern, Rural, and Remote Communities by Healthcare Excellence Canada. I'm Jennifer Major, and I'm a Senior Program Lead here at Healthcare Excellence Canada. So want to start out by acknowledging that I'm calling in from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. It's a beautiful day here, completely blue sky, cool air. I'm very grateful that I'm able to call this place home. I actually grew up in Corner Brook, Newfoundland, which those of you who've met me before know that I like to share. This is traditional Mi'kmaq territory. Most of my family still lives there, all within walking distance from each other, and I'm really looking forward to visiting there next week. Would love to see in the chat where all of you are calling in from and where you grew up. So a few housekeeping items before we get started. This session is being recorded. We're also pleased to offer French simultaneous interpretation for the session. So if at any time you'd like to hear the voice of an interpreter, please select French from the interpretation menu at the bottom of the screen. So to get there, you have to go to the bottom of your screen and you'll see an icon that says more on I think it's the right-hand side. So click that and a menu will pop up and you can select interpretation. And from there, you'll be able to access that feature. We invite you to share questions and comments at any point during the session through the chat box, and we encourage you all to respond and participate to comments that come in throughout the session. To ensure we can hear from all presenters, we will hold the kind of formal discussion, question and answer session to after the presentations are complete. So we'll have about 15 to 20 minutes for that. Looking forward to it. And if you require technical assistance at any time during the webinar, please send a direct chat message to tech support. And you can also, and we'll make sure that you get the help you need so you can participate. So I'm going to be your host for the next hour, as I mentioned, but I'm also thrilled to have three of our program coaches with us here today. So Kevin Sampson, Linda Lee, and Larry Bremner. So they've been with us for the journey on this program for the last year and a half, and I'm going to turn it to them now, actually, so they can introduce themselves briefly before we get going. So Kevin, over to you first.
Hi, thanks, Jen. I'm Kevin Sampson. Jen, do you want me to sort of talk about my experience as a coach, or are we just more of an introduction at this point?
You can how about introduce yourself and then we can talk about your experience as a coach once we get to that discussion segment.
That sounds great. So Kevin Sampson, I'm a family doctor. I'm in Ontario and I've been working with Healthcare Excellence Canada now for probably 3 or 4 years, I think.
Thanks, Kevin. Larry, over to you.
Hi, everybody. I'm Larry Bremner. I'm Métis. The person pointing out with the bald head is my grandfather, and beside him is my great-grandmother. She married a man named Moise Bremner. He is my great-grandfather, and his father, my great-great. We're two of 30 Métis people who signed a petition sent to the federal government protesting the giving of their land to the Prince Albert Colonization Company. It was ignored. They fought at Batoche. After Batoche, they moved to the United States and came back and homesteaded in Dormy, Saskatchewan in 1905. Former national president of the Canadian Evaluation Society and a fellow of the society. So thank you. I look forward to the discussion today.
Thanks, Larry. And we'll hand it over to Linda.
Yes, good morning, everyone. My name's Linda Lee. As some of you know, and some may not, Larry and I are life and work partners, so you'll see that in my slides. I come from a settler background, born and raised in Manitoba on Treaty 1 territory in the homeland of the Red River Métis. Larry and I are partners in Proactive Information Services, which Larry started in 1984, and I am also former national president of the Canadian Evaluation Society and fellow. And as you'll also see in the slide, I'm a big dog lover.
Thanks, Linda. All right, and we'll be actually joined by additional speakers who you're going to hear from soon, who are the teams, some of the teams in the program. So really looking forward to that. So in today's discussion, we're going to hear about and discuss example promising practice to improve safe, including culturally safe, team-based primary care in northern, rural, and remote communities. So those are practices that the teams in this program advance throughout the 12 plus months. We'll talk about some of the key success factors and lessons learned to support implementation, sustainability, and spread, some strategies that were used to enable community, health workforce, and First Nations, Inuit, and Métis partnerships, as well as reflections. How can these promising practices and strategies be adapted and spread elsewhere? And certainly invite you to reflect on that during today's discussion. How might these practices work for where you're calling in from? And these promising practices are actually available on the HEC website now, and we're going to include the link to the chat, so I encourage you to check them out. So the SPC teams, or the Strengthening Primary Care Teams, who participated in this program? Well, the program brought together 20 teams of primary care providers, organizations, and communities who worked together for about a year. So from November 2023 to November 2024, they were from and represented several northern, rural, and remote communities across 10 provinces and territories in Canada. One of the 20 teams, Newfoundland and Labrador Health Services, advanced 5 unique promising practices to respond to the needs of the people and providers throughout that province. And we actually heard from one of those teams during the part 1 of this webinar series. So, and teams at all stages of the improvement journey participated. So some of these teams came into the program with an early idea and a plan for what they wanted to do in terms of advancing a new practice to improve that access. Others had already implemented an improvement and were looking to spread and reach more people. All 20 teams had a common goal, which has been mentioned, to really improve access to safe, including culturally safe, high-quality team-based primary care closer to home in northern, rural, and remote communities. But they had unique focus areas. So the unique focus areas, which we can see on the next slide, included practices that focused on improving support and retention of the workforce, innovative models of care, improving access for people with and without a primary care team, appropriate virtual care, chronic disease prevention and management. We had teams that were advancing mobile health teams in really innovative ways. And there was a team that worked on advancing a practice to engage First Nations led governance structures around a new primary care organization that they were that has just been opened up, actually. And many of the practices, of course, even though this slide tells you some of the unique focus areas, a lot of the teams advanced practices that had multiple, like several of these focus areas. So for example, appropriate virtual care practices also focused on supporting the workforce and chronic disease prevention and management. So what were the supports that the teams got through the program? So seed funding, so up to $50,000 per team. There was virtual and in-person networking opportunities and coaching. The coaching really took an open door approach whereby teams were invited to reach out to HEC to request coaching for any guidance that they wish to have. So coaches also reviewed the implementation and evaluation plans that the teams created and provided feedback that the teams could consider. And each coach had at least one call with a team that they worked most closely with to really better understand what the goals that they had and what they wanted to accomplish, and understand if there were ways that we could help. The teams also were supported by HEC, as we mentioned, to co-develop those summaries of their promising practices, which we hoped help the teams share and their practices with other organizations and communities, and help them to generate discussion about how similar approaches could be adapted elsewhere. And we also, of course, supported the teams to advance their practices in any way that they essentially wanted us to help with. So what were some example impacts across all the teams? So this is always an exciting slide to present, and I feel like I won't do it quite enough justice. But we had 19 teams share with us a final report where they shared some of the impacts they achieved, including, very importantly, the patient and provider stories, which are very touching and inspiring to read. So this slide shows some of the overall impacts. We know from our teams that 66,000 plus patients were reached by practices that the teams advanced, which is very spectacular. Other example impacts, a lot of teams shared that there was improvements in provider experience, such as greater work-life balance and joy in work. Several teams talked about and shared with us that they had reductions in emergency department visits that could be for conditions that could be managed in primary care, improved patient experience and access for patients, so more timely access to care, and changes to promote culturally safe practices through partnerships with First Nations, Inuit, and Métis, and other equity deserving communities was also a common theme. Some of the quotes that we see and in those promising practice summaries that we had the link to the chat, certainly encourage you to look at those because almost all of them have quotes, and it was very hard to pick a few examples to put on these slides. So one of them, and we're going to hear from this team today, Regional Nurse on Call. With Regional Nurse on Call, my on-call nights were so much easier. I can sleep and be rested for urgent situations. Without it, I don't think I would still be working up north. Another team shared a quote that 75% of patients reported being seen at the annex, which is the practice that team advanced that was housed in a community library, helped them to avoid an emergency department visit. And another quote from a patient partner from another team, this program changed people's lives by helping with their pain relief and being able to get that treatment in their own community and instead of having to travel hours to get it elsewhere. So that's just an example of some of those, impacts from the patient and provider perspective that we heard from teams. And we were just very grateful that we were in a small part involved in this. So what were some of the key successes that teams shared that were fairly common across teams? Examples were collaboration, so collaborating with community and health workforce to ensure the practices met their needs, flexibility to adapt to challenges and community workforce input, sharing progress and good news stories, and making sure there was a constant feedback loop if you're asking for input from providers, from patients, to make sure you're circling back to share how that input is being used. Funding, of course, is always an enabler for improvement. So the funding that HEC provided was used for things like equipment for positions so that individuals had time to actually work on these improvement efforts and not be doing it on the side of their desk fully, and community engagement. A team, so who has the time to do the work, including leadership, a measurement lead, and a team lead, were always really important. What were some of the lessons learned? In the final reports, we asked teams about their lessons learned, and here's just some of the findings that were fairly common across the teams. Be a visible presence in the community. So several teams talked about the importance that meeting in person can help build trust and provide deeper insights into community ideas, needs, and opportunities. Building a diverse team with multiple champions to sustain the improvement journey, that could really help in terms of the staffing challenges that almost all the teams experienced. That, once you build those champions, if other people end up leaving or if there's staffing challenges, you have more people to kind of take over. The planning for sustainability from the start to ensure that people and resources are in place to maintain the improvements as an organizational and community priority, and don't be afraid to change the plan. So in this program, all the teams came in with an implementation plan that they certainly changed a lot throughout the journey. Several teams completely changed their plans because they realized it's not going to meet the needs of the communities, of the providers, or for other pressures. So, having that confidence to just start over or really amend what you had gone in there thinking you would do is certainly a lesson learned we heard from multiple teams. So that's a bit about the background for the program and the exciting results that we saw from all of this great work of the team. So now I'm going to transition to invite the three of the strengthening primary care teams to share about the practice that they advanced through the program, as well as to reflect on the value of the HEC program for them. We know this improvement work happens without Healthcare Excellence Canada being involved, but with our involvement, what value did the teams get in addition to what they normally would have? So on the next slide, I think we'll pull up. So first, I'm going to invite Judy Hill and Lisa Hawkins, who were part of the Petawawa Centennial Family Health Center based in Ontario, Renfrew County, Ontario, to speak on integrated virtual care. So Judy, I believe you are up first.
I am. Thank you, Jennifer. So I'm Judy Hill, the Executive Director of Petawawa Centennial Family Health Center, the admin lead of Integrated Virtual Care, or IVC, as well as sitting on the operations table of Virtual Triage and Assessment Center, or VTAC. So a couple of facts. Renfrew County is the largest landmass in the province. Renfrew County has a chronic shortage of primary care providers, and Renfrew County has an unattachment rate of approximately 20%. If we hearken back to March of 2020 and the start of COVID-19, a team of partners led by Renfrew County, Arnprior District Health, which included the FIT as well as the hospital, and included Dr. Jonathan Fitzsimon, and our own Lisa Hawkins, who will soon be speaking with you, they built VTAC in 10 days, the Virtual Triage and Assessment Center. At this time, the PCFHC's doctor shortage was further aggravated by a full-time doctor leaving practice to assist in the management of COVID-19 at the local hospital. The PCFHC started an immature version of integrated virtual care, and then when Lisa introduced me to Dr. Jonathan Fitzsimon, I call him my partner in crime, IVC was born. So IVC patients are rostered to a named family physician who works predominantly remotely. These patients are fully supported by a team of interdisciplinary health providers who can provide on-site care as required. Care may be provided virtually, on-site, at the patient's home with community paramedics, or in the clinic virtually with the virtual physician, all according to clinical need and personal preference. The benefits for the doctors include flexible part-time hours, work-life balance, no overhead, administrative support by the family health team. Did I mention no overhead? Benefits include vacation, sick time, personal leave, health and dental, CMEs, and the PCFHC started the Hospitals of Ontario pension plan in January of 24. The benefits for the family health team, this practice empowered my staff to work to the full scope of their practice in a collaborative fashion, which provided safe, high quality team-based care to people who had not been receiving primary care. Of note, it does not increase the workload for on-site doctors, but it does assist in equitable access to health care. How are the doctors paid? Funding models that are conducive to this practice include the blended salary model, or BSM, which is what the Petawawa Centennial Family Health Center is, and similar capitation models, as well as CHCs. And now a drum roll over to another partner in crime, Lisa Hawkins.
Thanks, Judy. Hi, everyone. As Judy mentioned, my name's Lisa Hawkins, and I work as a quality improvement decision support specialist with family health teams in the Champlain region. and also work as the primary care transformation lead for the Ottawa Valley OHT. So I get to work on many initiatives with Judy and also with Dr. Fitzsimon. And I'm going to throw a couple numbers at you. So as Judy mentioned, the official launch of IVC was in 2021. And since then, we have expanded to 2 more locations. So we have 3 family health teams locally that have the IVC program. We have 20 doctors employed, and we have been able to attach over 6,500 people who were unattached to primary care, which is fantastic. Now, this is a bit of a different way of delivering primary care, but it is still very much comprehensive, team-based primary care. And as such, our IVC patients have access to allied health and all the programs and services that come with that. So in terms of impacts, now these people are having access to preventative care. So we have cancer screenings and immunizations, chronic disease management. For example, 20% of the people coming into IVC who self-reported being smokers have now accessed smoking cessation programming through Petawawa Centennial Health Center. We also are able to see a reduction in emergency department visits locally, and we're still monitoring sort of what the impact is on hospital readmissions. Another important impact actually for the entire health center was the onboarding practice. So we really leaned on digital tools, really for the first time for things like signing a roster form, consent forms, intake forms, all of those things, building the chart quickly. And we're continually improving and changing and monitoring. But that process now has been taken on by the entire health center, even for the on-site physician. So that's been really helpful. Keys to success. There are lots has gone into making this program successful, but I'll just highlight 2 that I think are important to note. First of all, leadership. We have a wonderful admin lead in Judy, a wonderful medical lead in Dr. Jonathan Fitzsimon, but we also had a lot of support from the board, which was really important, as this was a bit of a leap in the beginning, and community partners have really been supportive as well. The other thing important to note, for this program to work, we do need access to in-person assessment sometimes. So we do have nurse practitioner time that is dedicated to this program. In some cases, it could be another physician within the group. And so the patient and their doctor are still at the center of their primary care. But if an on-site visit is required, then the patient is directed to have an appointment with the nurse practitioner on site. All that information is sent back to their doctor, and their doctor still then follows up, does any work that needs to be done, and considers next steps. And digital tools, as I mentioned, I'll just mention it one more time because I think it's super important. We're doing an AI scribe pilot with this program to see if perhaps scribes can help reduce the administrative burden for everybody in the both allied health and with the physicians. We rely on online appointment booking. Everybody has appointments available online. Many of our allied health programs and services you can access by self-referral and also book online. In terms of lessons learned, we've learned many lessons, and I'm sure we will continue to. But something that was really important, right from the beginning, we started collecting data and we were really thoughtful about it. And that's been very, very helpful. It's allowed us to monitor the program, essentially understand what the ingredients are in this program and what makes it work. We've been able to track number of encounters, et cetera. So that data collection has been key. We've also been involved in some official evaluations. So from a provider experience perspective, an evaluation on the program. And right now, we're very excited to be doing an evaluation of IVC where we can access ICES data. So we can actually look at IVC patients and see how much they used the health system and how they used it prior to being attached to IVC and what that looks like now. And so hopefully at the end, we'll be able to see sort of the cost benefit analysis of IVC and how it's working within the current system. Also, a really important lesson, you need to learn figure out how you're going to access your patients. We were able to use the VTAC system that Judy had mentioned. So we already knew the people who were accessing VTAC because they didn't have a doctor and lived in our region. And then we were able to offer people in their household to be attached to a primary care provider through IVC, which actually helped level out the sort of roster panel. And of course, Healthcare Excellence Canada has been so vital in us sort of getting to where we are now. So I'll just pass it back to Judy for a couple last words on how that help has been so beneficial.
Oh, you're muted, Judy.
You'd think I'd know how to turn on unmute in these situations as well. So Healthcare Excellence Canada has increased the value of our program on numerous levels. One certainly is the superb coaching that has been provided. The structure, especially when it comes to patient participation as well. They encouraged us to increase our use of patients in the process. Networking and linking to experts in the field, whether it be medical or whether it be virtual experts. Assistance with design. You have the talents, we don't. Financial support. Last but not least, encouragement. And of course, our resources have now been shared with OH and the Ministry of Health as well. And I see a number of people wish us to share our data going further. So that's just lovely. Thank you very much.
Thanks so much, Judy and Lisa. And yes, I see some comments in there. And I know this is IVC. So Judy, Lisa, and Dr. Jonathan Fitzsimon, they certainly are doing, like they said, that really robust evaluation and have actually some publications in peer-reviewed journals, I think, on IVC in a similar initiative, VTAC, that it came from. So yeah, Judy, Lisa, if there's any articles that you're able to share, that would be great. And I know there's some questions in the chat that you may want to just pop in and answer as well. So you can do that. And we'll, of course, get to our discussion segment shortly. Before I hand it over to our next team, I will mention, so one of the things Judy had said was the support that HEC provided in the design. So that would be related to the design of, for example, those promising practice summaries. So we created a template for that we thought might be, very eye-catching, and helped with the copy editing and the creating of the content for that. So it was a tool that the teams could share and use in conversations and discussions with funders, with other communities, with other primary care clinics, to support them to learn about and understand how they could implement that themselves if it was a fit. Another two resources that Esther popped in the chat earlier on that we created with the integrated virtual care team, so Judy, Lisa, and Jonathan, included two things. So one was an IVC guidebook, and a second was a patient navigation guide. So the guidebook that's linked in the chat just a little bit above where we are now, and if you just scroll up, essentially drew on insights from the implementation and evaluation from integrated virtual care, and was meant to provide, and is meant to provide, practical guidance for organizations that are considering adopting an IVC program. So it explores how IVC can be integrated into existing team-based primary care models, the steps required to achieve this, and strategies for optimizing performance once established. And it also serves as a reference for existing IVC teams, so the one in Renfrew County, and there's two other clinics it's in now in Ontario, to help provides guidance on how to train new staff, how to document and inform policies and procedures, and facilitate continuous improvement. And within that IVC guidebook, there's also a patient navigation tool, because as we worked with the team, they said to us, well, what about the patients who are now rostered and part of an IVC clinic and practice? How can we better share with them the services that they're able to access through IVC? So we actually went to Renfrew County with a designer and met with Judy, Lisa, patient partners, and created a one-page patient navigation tool that shared that information. So just wanted to share, those are some examples of kind of that open door approach that HEC takes. So a team knocks on our door and wants help with things like that are going to help them advance their improvements, and we hope to be able to help. So anyways, thank you, Judy and Lisa, for that presentation. So I'm going to hand it over to Raisa to introduce yourself and then tell us about the practice you advanced through the program. Is Raisa there with us? Or maybe I have to, maybe, are you on mute? We could also, I don't know if, do we want to, Raisa, I'll give you one last chance, and then maybe we can just go to, we'll hop to Francois instead.
No,
there you are,
it's
Raisa.
good now. I didn't
Okay.
have, I was just typing that in. I didn't have permission to unmute.
Oh, okay.
Sorry.
Sorry, our bad.
No problem.
Go for it.
All right. Hi, everyone. My name is Raisa. I'm the assistant head nurse for Regional Nurse on Call. I work with Frédéric, who is the assistant director of nursing. We both work for the Cree Board of Health and Social Services of James Bay, located in James Bay, Quebec, the Cree Nation of EUHG. So to provide a bit of background, the EUHG consists of 9 remote communities, 2 of which have 24-hour clinics, while the remaining 7 communities have clinics that are open Monday to Friday, 9 to 5. And in those clinics, nurses rotate being on call outside of the opening hours. So the challenge that we faced was the critical shortage of nursing, and it led to nurse exhaustion and resignations, and therefore decreased access to primary care for the communities. So in response to this, our promising practice was to create the Regional Nurse On-Call Service, RNOC. It's a centralized virtual triage service staffed by Cree Health Board nurses. It was designed to improve patient access to care while alleviating the after-hours workload for nurses in the communities. So from 8 p.m. to 8 a.m., calls for primary care services in the 7 communities are transferred to a regional nurse who performs a telephone assessment and triages the calls appropriately. So non-urgent calls can be resolved over the phone, or appointments for the next day can be booked for them, and any urgent issues are directed to the clinic in their community for an in-person assessment. So we've had several key factors since the launch of RNOC service. In 1 year, over 6,000 calls were triaged by regional nurses, and of those calls, 52% of health issues were successfully resolved over the phone, thereby reducing the non-urgent calls and visits to the clinics during the night. This reduction in calls decreased the workload at the clinics for the nurses, and enhanced the impacted retention, and has improved patient safety since nurses are there. and have a more manageable workload. Furthermore, the regional nurses have actually we're also able to provide food, which is new since regional nurse on call. One of the biggest challenges that we faced was the community adapting to the change in the nurses they were used to else. So you develop this relationship to help connecting with the people there in order to gain their input, their expertise, and to launching. This in turn established direct relationships and communication between our team and the community and the leaders in the community. We were also able to obtain licenses for software based, and it allowed us also to provide education for the regional nurses on telephone triage. Our coaches, Linda and Larry, gathering in Winnipeg to meet and learn from others who are working on similar projects, and to connect with people was very inspiring for the program as well, and for us. And nice that other work is being done as well, and learning about new ideas too and new programs. Continue to create connections with partners in the community, so midwives and the psych hotline. We've collected data from the start, and we continue to collect data and are in the process of evaluating the quality of telephone triage, and to see if there's a difference from before the start of the regional nurse on call program till now.
Thank you so much, Raisa. And what an excellent example of an initiative that both improved the experience and outcomes for patients, but also for the providers, so that they have what they need to really support the patients, but also to have that work-life balance, and for themselves to be able to really do their job as well as possible. And so thank you so much for that. So the third team we have is Advanced Access Quality Improvement Coach Model. So I'm going to hand it over to Francois, who will introduce himself. And Francois, you'll let us know when you want us to pop up the results slides. So over to you.
Thank you so much. Well, hello, everyone. I'm François Bordelot. I'm a research coordinator and coach at the University of Sherbrooke. And we're working on advanced access. We've been working in advanced access for quite some years now, but we've developed about 37 primary care clinics that we've helped throughout the years. And for this practice, we focused on 4 clinics, all in many different regions across Quebec. And for these 4 clinics, one of the problems was really to ensure that patients obtain access to health services when they need, and depending on their needs, because we want to shift the focus from primarily doctors to multiple different health professionals. So nurses, psychologists, social workers, physical therapists. So we really want to include as many health professionals as possible. And one of the challenges that we faced in rural and semi-rural clinics, there's 2 main challenges. One of them is that most clinics are decentralized. So there's multiple sites all across the region with 1 or 2 doctors, some health professionals, so smaller teams, but that are all decentralized. So just having everyone work together is a bit harder than in bigger clinics in urbanized areas. One other problem is that often there's not enough medical doctors, there's not enough teams to provide services for everyone. So this leads to the problem that many patients don't have a family doctor to their name, which leads the teams to have a bigger need for populational services, which leads to difficulties having access for patients. All of this means that we really wanted to coach these teams and help them improve their advanced access processes. Our promising practice is in 3 steps. So first, we get together the team, we have a team reflection, we set the priorities, we set the aims, the measures, we set what we want to achieve with this clinic. And this is one of the most important part of the process, because often, especially in rural, like I said, decentralized clinics, it's one of the only times where all the teams get together and can share ideas and reflection about what they want to achieve in their region. So this was really, really interesting, especially with this program. And then we engage in plan, do, study, act cycles, so PDSAs, basically just improvement cycles, but based on the changes that they want to implement. Rather than going top down and with ideas that we already have. So we really try to include them in the process as much as possible, including everyone at the clinic. So it's not only doctors and managers that are included, but really everyone, including administrative agents, including nurses, including, like I said, physical therapists, social workers. So everyone at the clinic is involved in these cycles. And then we can also have group mentoring with primary care teams and coaches. So we can share successes across clinics as much as possible to improve support sustainability and help spread the good ideas that have come. We had some impacts, and I have some slides for the more visually inclined people that could be shown up now. It's just to show what some of the impacts that we have. We have multiple data that we used. One of them is the third next available appointment, which is regularly used in advanced access measuring to show improvement. And some clinics, we had great impact. So for some clinics, for example, this one, we had 2 weeks approximately for the third next available appointment. So there was no availabilities for patient at all, including their own patients, but also patients that were not assigned to a medical doctor. So even the general population didn't have access to doctors at all. And we shifted all of this to an average of about 6 days with a low of 2 or 3 days in third next available appointments. So we had some great results with some of the clinics where we really helped improve access for patients, including urgent care, including follow-up care. And in general, this also improved patient provider experience for all across the clinics, because they really feel like they have a reduced workload, they have fewer administrative tasks, greater work satisfaction. So we really both improve access, but it really gives a breath of air to the providers too. Not all the clinics have had great results. Some clinics already have great access. For example, this one was already going around 2-3 days after next available appointments. So access wasn't the priority. But for this clinic, for example, we really work with them on what they wanted to improve. And what they wanted to improve was better access for nurses, better collaboration. So simplified trajectories for patients who had access to social workers, to nurses. So having access directly to the professional that they needed rather than only medical doctors. So even when access was already great at these clinics or good, we had focused elsewhere on access to other health professionals. What we found were the key to successes. Funding for external QI coaches, funding for meetings, for data collection, all of these really helps. We know that advanced access can help improve access with clinics, but they often don't have the resources to build these strategies in their clinics, to develop strategies to share across clinics. So we really found that having QI coaches dedicated to these clinics really help improve. Even when they already wanted to improve, they needed help to do so. So we could help this way. And having a local improvement team that was inclusive. So having, like I said, administrative assistant, physician, nurses, managers, social workers, like everyone at the clinic being involved in the process was really, really important to improve access and to build engagement from the bottom. Some lessons we learned. First, like I said, having an external coach really can free up time for a team reflection. They can focus on really their team reflection, developing creative strategies, and not worry about all the data collection of the more structural things, and they can really help them find new ways to improve. And on the other side, when they don't have these, like, for example, when there's big challenges at the clinic, there's great changes, it's difficult to really allocate time for improving. So really dedicating time for improving really helps this team. So it means that it's difficult to compress time for these interventions. We have a minimum of maybe 16 months, maybe 18 months time frame to ensure that really we can improve on the larger scale and really really improve and show improvements. Shorter time frames don't really give us enough time to improve, to build strategies, to build the team, and change the culture inside the clinics. So we really need time for these lessons. And one of the things that really helped was the HEC program, which helped us learn from other teams across Canada. So really what worked, what didn't work, what they already tried, so we could save some time and go beyond what we had experienced ourselves. So really sharing across teams and meetings such as this one today really helps us learn about what's going on and new strategies to improve. So yeah, I think that's it.
Wow, Francois, thank you so much for sharing that and what amazing results you have. And, you know, the importance of building those improvement efforts with the teams from the very beginning, the clinic, so that they're the ones who are steering the improvements and the change ideas and really engaged along the way. Like what an amazing work that you've done with your team. So super excited to hear more about that. Thank you so much to all of our presenters. We have just a few minutes for some reflections and discussions. Please continue to engage with the chat, but I wanted to hand it over to Kevin to share a little bit about himself and his role as a coach and how the program was a valuable experience from your perspective. Over to you, Kevin.
Thanks, Jen. And I think I'll echo your remark and just say, wow, like it's great to see that the teams have done so well. So congrats to the teams. And I also really want to say, you know, thanks to HEC for pulling this together so well. So congrats to you too. So like I said, I'm a family doctor. I also have a background in biomedical engineering with a focus on digital health technology and virtual care. So I can offer a practical clinical provider perspective. And like I said, I've been with HEC for a while. I've been involved in a few programs, and it's been really great to see how each program builds from the other. So lessons learned, knowledge gained, connections made. I've been really impressed to see the variety of projects supported as well. So in terms of scope and scale and stages of development and diversity of populations, like you've seen, it's been awesome to see all these creative, innovative approaches and just the passion to improve care, especially, you know, given the limited resources in the healthcare system that we're all facing. And also the projects, you know, it's not just about solving a particular problem in a particular community. They're about learning and developing principles and practices. And it's really exciting to see, like we have, that many of these projects can be adapted and scaled up to help other communities, even right across the country. We've all seen the value in partnering with patients and patient coaches. And, you know, at the last meeting, it was said the term coach somehow wasn't quite right. And I've been thinking about that. And I'm not sure what a better term would be. Maybe facilitator or implementation partner. I don't know. But I do agree. The reality is that we're really all learning from each other. This program's shown me the value of patient-centered care, equity, cultural humility. It's really strengthened my commitment to take a more informed approach professionally and especially also personally. And I'm really grateful for that. I've thoroughly enjoyed working with everyone at HEC and the excellent teams that have achieved so much. And I'm grateful to be here and working with you folks. So thank you.
Thanks, Kevin, for the reflections. And similarly, we enjoy working with you, and I'm sure you'll be continuing to be involved in other offerings that I'm going to give a sneak peek about shortly. So thanks for those reflections.
I hope so. Thank you.
I have Larry up next, and I thought you could comment briefly, Larry, and we would love to stay here all day. But all the teams in the program advance unique practices really to improve that equitable access to safe, including culturally safe, team-based care. So just wondering from your perspective, how primary care organizations can best identify and partner with equity deserving people and communities so that they guide that improvement effort together and ensure that patients benefit from the practices.
Excuse me. I think, well, first of all, I'd like to thank everybody for the presentations. I really appreciate the work you've done and the dedication to your programs. And I think we've had some good examples. What I always start out from is the communities have to become true partners. This staff can have a plan, but you need input from the community to make sure that it resonates with them and it authentically reflects their realities. I always say community members are the experts in their own realities. And so that's one thing I'd suggest. We've heard from some of the other presentations in terms of equity, having advocates, having rooms that are culturally safe and reflect community, having the food, traditional foods. One of the things we hear is having the ability or the opportunity to look outside of the normal way of doing things, so that in fact, you're not only providing access, you're providing equity in terms of program delivery as well. Somebody made the point, and it goes back to the importance of community, is being seen in the community, being visible in the community, getting community input, whether it be through storytelling, whether it be through sitting down and interviewing. They will reflect the value that they see they're receiving through what you're doing. And the importance of leadership, but not only organizational leadership, but leadership in the communities, to ensure that community needs are being met in an authentic way. That's just a few things I would suggest.
Always very informative and grateful for your sharing, Larry. So thank you so much for that. Linda, I want to just hand it over to you briefly now before we almost close out this webinar. So one of the things you said in the first part of the webinar series, we had asked, to reflect on some of the value of the program, and some of the examples shared were the promoted cross-jurisdictional learning, raised awareness and capabilities within teams to incorporate those stories and patients and community perspectives, and also that HEC supported the teams to be creative in designing, implementing, and evaluating their practice. So I just was curious more if you want to reflect more on that last piece, like the importance of supporting and encouraging teams to be creative in their promising practices and improvement efforts.
Yes, thank you, Jennifer. I think we've heard from the teams, and thank you again to all teams who presented here today, as well as hearing from other teams and the amazing work that people are doing. And it's been a joy to be part of this project. I think that what I love about it too is that HEC adds so much value. They're not just giving you money. They're giving you that value added and people have talked about coming together in Winnipeg and being able to share through things like these webinars, developing a real community of practice. But I think that one of the real beauties of HEC is allowing that creativity and letting people go from where they are. So they support all stages of projects at all different places in implementation. And if people need to change course because something's not working, then they support that as well. So the support begins in design and goes right through implementation. If people need to take a different path, then that's fine too. I think also supporting creativity in things like evaluation, and we love to see those numbers of increased access, but we also need to hear those stories, and supporting that kind of multifaceted evaluation, I think is really important. And just to conclude, just quickly, is that Jennifer mentioned the open door approach, and I think that's part of it. I believe teams could always feel comfortable in saying we need this, or drawing on the supports they needed. So, and that support, as I say, going throughout the whole project, the life of the project and beyond. And I think that's what Jennifer is going to talk about next.
Thank you so much, Linda. We'll have to have a part 3 of this webinar series so that we can hear more. So I'm going to jump into just giving a sneak peek of some of the new offerings that HEC has. And again, thank you so much for all the presenters today. So coming soon, we're going to be sharing more detail about upcoming offerings. So if we just go to the next slide, I'll give you a sneak peek a little bit about what that is about. So we have a stream of program offerings come up that go into the topic areas you see here. So those that expand safe, person-centered care and long-term care, that support older adults to age where they call home, to improve work environments for healthcare providers and leaders, and to expand access to care and ease pressure on emergency departments. So if we just skip to the next slide and maybe even go to the next slide. Here's some of the offerings that we're going to be, there's going to be a webinar in May to tell you more about these, and we want you to sign up to our newsletter so you can learn more about them. So one of the new program offerings is called Primary Care Access Improvement, and all these offerings are under that umbrella of reducing avoidable ED visits with team-based care. And we want to strengthen what organizations are already doing in these areas as well, taking that strengths-based approach. So Primary Care Access Improvement will support team-based primary care organizations to implement a contemporary advanced access model that will enable patients more timely access to care while ensuring continuity. So you heard Francois talk about advanced access, and this program and offering is going to essentially, it's based on the work that Francois and his colleagues Isabelle Gaboury and Milan Breton have led, as well as work from the Alliance of Healthier Communities Ontario. So stay tuned for more about that. There's a paramedics and social prescribing program, which is going to support paramedic teams to improve or further embed social prescribing into their service models. On the next slide, we also have an enhancing integrated care program that will support primary and community care organizations, enhance integrated team-based models of care, and a Right Care Challenge program that will support organizations that have recently started an initiative or are improving existing initiatives to expand care and reduce pressure on emergency departments. So how can you find out more? Sign up to our newsletter so that you can get the information on those webinars, and as soon as those program offerings are launched. We'll also pop in the chat. We just actually issued our executive training program. That's available now. Check that out. And before you go, I know we're a bit over time. If you could please complete the survey for today's webinar, that really helps us to improve on our processes and make sure that we're offering webinars and learning activities and offerings that are going to be resonating with you and help you achieve excellence in healthcare as well. So that's there on the screen. So thank you for completing that for us. And I just want to say that as you're completing that survey, thank you so much again for coming today. A huge thank you for all the speakers for joining and the amazing production team that we have behind the scenes, who really are the people that make this opportunity happen as well. So thank you so much. That is a wrap of the Strengthening Primary Care program, but it's not the end of the work for any of the teams as well. Hopefully those teams can continue the work through those new offerings I mentioned. So thank you so much and have an excellent rest of your day and week.